Thanks for your attention, you guys. My name is Stephanie DeCiciolo, and I lead the Impact and Evaluation Department and our National Health and Housing Program at Enterprise Community Partners. Enterprise, you've heard a little bit about us through the conversations earlier today. Enterprise is a national nonprofit working to make home and community places of pride, power, and belonging, and platforms for resilience and upward mobility for all. In short, we exist to make a good home possible for the millions of families without one. And we do this in three ways: by investing capital to create and preserve affordable homes, by supporting innovative solutions to seemingly intractable problems, many of which we've heard about earlier, and by advancing housing policy at all levels of government, federal, state, and local. And in addition to those things, we also own and operate nearly 14,000 units of affordable housing in the Mid-Atlantic, giving us a 360-degree view of the entire affordable housing industry. I'm really excited to be the moderator for this panel today because Enterprise has been working at the intersection of health and housing for a very long time, beginning back in 2004 with the launch of our Enterprise Green Communities program and the creation of our Green Communities criteria, which remains today the only green building standard developed exclusively for affordable housing. Our National Health and Housing Program leverages all of the expertise that I just spoke about to enhance resident health by bringing together the housing and health sectors to address the needs of our most vulnerable populations through both the built environment and programmatic initiatives. And through our work, I've had the pleasure to collaborate with many of our panel members and have enjoyed getting to know the couple that I didn't know already. And so let's get into it, and I'll introduce our esteemed panel today. Dr. Megan Sandell is a professor of pediatrics at Boston University Schools of Medicine and Public Health. She co-directs the GROW Clinic for Children at Boston Medical Center and leads the place-based investing portfolio at BMC Health System. She is a nationally renowned expert in housing and child and family health. Dr. Sandell has served on many national boards, including Enterprise Community Partners and the National Low-Income Housing Coalition. And she's previously served on committees on environmental health for the Centers for Disease Control and Prevention and the American Academy of Pediatrics. Andy McMahon is the Vice President of Impact Investments with the Health Equity Strategy Team at United Healthcare. Or United Health Group, excuse me, Andy. In his role, Andy works closely with the United Health Group Treasury Department on their tax credit and social impact investment portfolios, expanding and diversifying the ways in which they invest to support communities across the country. Steve Waltrip is a founding partner and chairman of Rocky Mountain Homes Fund. His background in law, real estate development, state legislative office, and service on charitable boards focusing on community health and housing give him a unique ability to create innovative housing solutions. As vice president of the Quantified Ventures Health and Human Services team, Allison Ryan works to develop new earned revenue models for nonprofits that mobilize capital towards solutions that improve health equity and address social drivers of health. And last but certainly not least is Kevin Kretschy, who is the Chief Capitalization Officer at Gulf Coast Housing Partnership. And his role at GCHP is to lead efforts to source, deploy, and evaluate the impact of concessionary capital sources utilized by GCHP and its partners in transformative real estate development efforts focused on creating and sustaining vibrant, equitable, and affordable Gulf Coast communities. So you can see we have a diverse but extraordinarily accomplished panel today with a lot of interesting perspectives to bring to this conversation. So let me get started. Megan, you've been working at the intersection of health and housing for a really long time. And in fact, you really brought this issue to the attention of Enterprise and helped shape our National Health and Housing Program. Can you share what brought you to this work?
Well, first of all, can people in the back hear? Thumbs up? Are we good? Awesome. I just want to thank the Health Foundation of South Florida and Miami Homes for All. This is just an amazing day, and being able to be part of it is just a huge honor. So I just want to give them all a round of applause again. It's just been an amazing, amazing day so far. I've learned a ton. So I think one of the things that I say is I'm a pediatrician by training, right? I'm a doctor. And the people who teach me the most are my patients. And so I learned about housing and health from my patients, right? And the story that I like to tell is I work at Boston Medical Center, what was originally actually Boston City Hospital. We are, in many ways, the Jackson Health of Boston. We're the largest safety net institution in New England. And I was learning to be a new pediatrician, and I was in the pediatric ICU, and a kid got admitted to the ICU with asthma. And their family was pretty mystified. Like, she had pretty well-controlled asthma before, and all of a sudden now she had this awful attack. We were like giving her constant medicine. We were thinking about putting a tube down her throat to help her breathe. It was bad. And I ended up asking the family kind of this fateful question, which was, what had changed? And they talked about getting a cat. Any guesses why they got the cat? Mice. So it was this like moment where this family described this harrowing experience of finding mice droppings around her bed. And they got the cat because they couldn't get the landlord to make a difference to the panelists this morning for Miami Workers Center. And they ended up with this allergic reaction. She was allergic to cats, and she ended up in the ICU. And for me, it was this kind of eureka moment where I was like, oh my goodness, I can't send her home to that environment. I want to write a prescription for a healthy home, and that's not stocked at the pharmacy at my hospital. And so it was this idea of like, what does this look like? So quality was where I really started, and doing a lot around thinking about medical legal partnership and having a lawyer as part of the healthcare team. But then it really wasn't a healthy home if it wasn't affordable, if it wasn't stable, and visiting families with Boston Healthcare for the Homeless and thinking about that. And I think ultimately now it really is about a stable, decent, affordable home in a neighborhood of opportunity. And that's where, to me, my patients continue to teach me where systems are broken, teach me where systems can work. And that's what's exciting about today, is hearing how Miami can do that too.
That's great, Megan. Thank you. Steve, you've been partnering with Intermountain Healthcare. It's okay. We got a little mixed up. It's totally fine. You've been partnering with Intermountain Healthcare for the last several years. Can you tell us how that partnership got started and what its goals are?
You bet. Thank you. And I'll just say thanks to Janice for bringing me here today. It's much warmer here than it was at 18 degrees at my home in Utah when I left yesterday. Intermountain Healthcare is part of a group called the Impact Partnership in Utah. And it's made up of Intermountain, Zions Bank, one of the leading regional banks, Miller Family Foundation, which is a wealthy entrepreneurial family, and some other partners that have gotten together and said, we need to positively impact the lives of Utahns. And Intermountain has taken the lead in social determinants of health, of which housing is one. And so when we approached Intermountain with this idea of a fund, and they got very excited about it, they gave us our first $1 million investment. They also committed several $100,000 in grant money to help us pay some of our legal bills, which were quite extensive. And so they were our first champion and are still our best champion. They just committed another $25 million of investment to our fund, and have been leaders in soliciting others to join in the opportunity to change housing for what used to be the middle class of America.
Great, thank you. And did you have slides that you wanted to share?
I do. Is that?
Yeah, that'll
we do
be
it
fine.
now? All right,
Yeah,
let's do it now. All right. Do I click now? There we go. All right. Rocky Mountain Homes Fund. I'll give you a very brief introduction. I wish this clock was running because I can talk for so long about this, but just tap me, Andy, if I get going too far. Rocky Mountain Homes Fund is a social benefit fund that was created to provide opportunities for home ownership that are rapidly vanishing in America. In Utah, for instance, 90% of the people who are not currently homeowners cannot afford to become homeowners. And I hear many of the same statistics today. Utah says that Salt Lake is the least affordable community. I heard Miami is now the least affordable community. I think there are many others. Boston is the least affordable community. The reality is this: 99% of the counties in the United States are at their least affordable point in their history. So it's not just one place, it is every place. So we started this a few years ago. $750,000 of startup expenses. Intermountain provided $300,000 in startup grant funding. They were initial equity investor. We also had money from Zions Bank and lobbying support to get money from the legislature. Rocky Mountain Homes Fund we established in 2020 to create a path to provide home ownership for working families. What we do is we qualify participants, we bring them in, give them a budget, just like a regular home lender, but what we do differently is we assemble impact capital and partner it with traditional housing debt. So the debt and capital are mixed 50-50. The capital side, the investment side is interest only, and then the other half is debt on a traditional 30-year amortized basis. So because of that, our payments are significantly lower than they would be for a traditional 30-year mortgage. For instance, if you were to go out and get a $400,000 mortgage right now, your payment's going to be between $3,500 and $4,000. With our program, that payment is about $2,100, so it's significantly less. The way that we do that is we provide stable monthly payments for up to 10 years. We give homeownership training and financial education. And then we also, for each participant, establish a 6-month custodial account. It's their money. They don't have a down payment when they come in. They provide 2 months, first and last month, similar to what you would do on an apartment or another rental. We take that money and we partner it with, or we match it with money from the investment side and money from the debt side. We have a custodial savings account that gives them a 6-month cushion. It's their money, but we control it. So if they get into a life situation where they have, for instance, we had one lady that got COVID and couldn't work for a month. She couldn't pay her payment. So she applied to us and said, hey, I need money to cover my payment. Now, it turned out that Intermountain Healthcare, who she worked for, had a program where they actually ended up paying her rent for her. But initially, she had the opportunity to do that. If we have somebody that has a water heater breakdown or a roofing issue or a car breakdown or a medical bill or something that typically would put someone in that position of having to decide, do I eat, do I pay my rent, do I pay my phone bill, do I pay my kids' school fees? We want to remove that burden from them, and so we create kind of a forced savings account for them that they can draw on, and then once they draw on it, they have to refill that bucket over the next year so that they have a perpetual source of backdrop for it. We've assisted to this point, we did a $2 million pilot with Intermountain Healthcare's funding. We have done then an $18 million follow-on round that assisted 50 families. We're now in the middle of a $300 million fundraise effort for the state of Utah. We have homes all across the state now, and we're now looking at, the reason we're here today is because we're looking at taking this model and taking it across the country to many other communities. We think this is a very scalable model. It provides opportunities for normal people, teachers, healthcare workers, frontline healthcare workers, nurses, others who used to be able to afford home ownership to be able to get back into that to start building equity. We have, at this point, 100% payment compliance because we also do direct withdrawal from their paychecks. They volunteer for that as part of the program. And then we've created now to date about $1 million of equity for the families we have in our program, which over the course of a couple years is very significant for these families. And we look forward to doing a lot more in the future. I'm going to skip this page here and that one there, and we'll go to this one where we have candidates go through 3 interviews. They're judged on financial fitness and readiness to succeed. We have a board who complies with the fair housing laws. We're blind. We have numbers only. We don't know race, nationality, gender, marital status, any of that. We know household size and their numbers, and then we approve them. But we have a team that goes through and does individual interviews with each of the participants prior to that approval so that we can get to know them, get to know their circumstances. Very briefly, our very first participant was a lady who had a bankruptcy and a foreclosure within 3 years of her application. Typically, she's out the door. She doesn't get to apply for another 4 or 5 more years. We talked to her. It turns out she got divorced, got the house, and then immediately got cancer and couldn't work for a year. So she had paid her bills all before that. She paid her bills all after that, but she had this period of time where she was just out of luck. And we admitted her to the program. She was our first graduate. She walked away. Her kids moved out of the house. She said, I don't need this big of a house. She walked away with a $20,000 check from her time in the program, where had she been renting, obviously she would have walked away with nothing and probably lost her deposit as well. So that is, in a very brief nutshell, our program. It's been tremendously successful. We think it's scalable, and we want to take this to other communities throughout the country because we think this is a solution to the growing problem of the lack of affordability for, again, what was once the normal working class. How many of you grew up with teachers that lived in your neighborhood and police officers that lived in your neighborhood? That is an absolute rarity now. Kids growing up, if anybody has kids that are hitting the housing market right now, they are living in your basement. So congratulations. We're trying to solve that problem. Thank you.
Thank you. Steve, sounds like a wonderful program, and I wish my son, who lives in one of our bedrooms, lived in Utah. All right, fair enough. All right, I'm going to skip over to Kevin because I never do anything in a linear fashion. And so, Kevin.
Hello.
Hello. You are a longtime partner of Enterprise Community Partners and an early adopter of strategies that bring housing and healthcare together for the benefit of your residents. Can you tell us a little bit more about that work that you do?
Sure. So our health and housing initiative, we've always focused on health as a nonprofit affordable housing developer, but really in around 2014 or 15, we had a group of historically black churches in Jackson, Mississippi, who all had land and wanted to use that land to both create affordable housing and try to impact the challenges that they were seeing in their communities with health. So that was our first real push into what health and housing might look like. And around the same time, we had applied for Section 4 grant funding through Enterprise Community Partners, and were successful in so thank Enterprise for that initial sort of seed idea capital, and began to explore with those groups. And now we're at the point where we have got people moving into our first health and housing pilot development in New Orleans, and in the next few weeks we'll have people moving into our first in Jackson, Mississippi. So there's 2 pilot health and housing transactions that both received concessionary investments from healthcare payers, specifically Medicaid MCOs.
Great. And did you also have some slides you wanted to share with us today?
Sure.
Okay.
Okay. These are in Utah, I think. They look great. Okay, so and just kind of stepping back a little, I loved what David said this morning about if you see a problem and don't know what the solution is, make it bigger, because I didn't realize till this morning that that's effectively what we did. As an affordable housing developer, working in the Gulf Coast, every affordable housing developer has challenges. In the Gulf Coast, we have some of the lowest income levels in the country, and we don't have some of the lowest construction costs in the country. We also have limited per capita federal sources, and the philanthropy that we have in Louisiana, Mississippi, and Alabama, where we predominantly operate, is not robust. And so we always have gaps in affordable housing development, and those gaps continue to get bigger with the challenges that we've seen in the last few years with insurance and all the things that we've talked about multiple times already. So what we looked at was that we are also typically trading in the bottom 3 of health outcomes throughout the country. So Mississippi, Alabama, Louisiana, if you're born there, you will live a shorter life than if you were born anywhere else in the country. And so we had these 2 challenges of predominantly working in low-income, BIPOC communities and populations, and being unable to deliver the affordable housing that we wanted to see, and being unable to have much impact on health other than being able to provide that housing. So we looked at those two problems together to see if we could find a solution that would not be a silver bullet, but could be another step toward creating more affordable housing. And so we looked at the Health and Housing Initiative and starting to create it, and one of the big key pieces was concessionary capital. Jim, who works with the CDFI, was up here earlier talking about all the typical resources you use in affordable housing development. We use all of those. The two pilot projects that we that we'll see in a minute used both New Markets tax credits and capital magnet funds. The one in Jackson, Mississippi set a record for us of 17 financing sources within the capital stack, including 5 different types of tax credit equity. But that's often not enough because there's not a scalable source of resources beyond that in our region. So we wanted to look to a source that would benefit from housing and positive health outcomes for the populations that we serve, and we landed on Medicaid MCOs, managed care organizations that we operate in the states that we operate in. So one of the key pieces for our Health and Housing Initiative is to get concessionary capital from Medicaid MCOs or healthcare payers. And that's come in 2 forms so far. One from United Healthcare, and Andy and I have been talking for a long time about it. It came in the form of low-cost debt. And then another, Aetna, in our New Orleans project, came in the form of much higher than market pricing on low-income housing tax credit equity. One of the other issues that we faced in our region is that for 4% low-income housing tax credit transactions, they're vastly underutilized because they're just not enough to make a deal work. And so bringing healthcare payers in was another source that could help to make 4% deals work. Another key component that came really from our partners in the Jackson area and the churches that we were working with was culturally competent healthcare services. And so we've got, for both of our pilot projects, we've got an on-site federally qualified health center that has at least one community health worker who will be dedicated to the residents of the facility that we are creating. And that's been a really important key component of understanding interaction with healthcare and broad social determinants. Our health and housing transactions are also healthy buildings. They'll be respectively the first Fitwel certified multifamily developments in Louisiana and Mississippi. Fitwel is a standard based on CDC research on the impact that buildings have on occupants. And then another really key piece we hope for scalability is that we have a data-driven approach where we've been working for almost 2 years now with the federally qualified health centers that we're working with on site, as well as the MCOs who have invested on data sharing and evaluation that's going to go years beyond closing the financing and building the buildings. So it's very exciting. The partners, we come in as the real estate developer, nonprofit that brings that capacity and tries to stay within our own lane. Many challenges that we see is that other folks try to do more than what they have expertise and capacity within, and so we try to be the experts and learn as much as we can on healthcare. The healthcare providers I mentioned, and then social service providers and healthcare outcome evaluators as key components. I will not go through all of these, but we have, one of the things that we've been doing over the last year and a half is, at least on a monthly basis, for each project, we've been getting medical folks from the MCO who is involved and medical folks from the federally qualified health centers involved to talk through how we want to evaluate outcomes and where that data is going to come from, and have been going through the process of data sharing agreements and even bringing on additional resources to help us with that. We've recently brought on the Louisiana Public Health Institute as an expert repository of data for the health outcomes that we'll be evaluating. So this is a set of some of those metrics. And then I'll just really briefly go through our 2 health and housing developments. This is the H3C development in New Orleans, where, as you can see, right downtown, it's 192 units of senior and family units. One side of the development is family. The other one is an LGBTQ plus affirming senior development. And then the ground floor is a federally qualified health center and a community health worker training center. And then this is the Pearl. It was an abandoned hotel in Jackson, Mississippi that is finishing construction in the next few weeks. We tore down a part that was non-historic, but this is the one that had 17 different financing sources, including 5 tax credit equity sources. And we're very excited. It'll be an on-site federally qualified health center with 76 units of senior housing.
Wow, yeah, 17 sources of financing. That's amazing. Okay, so one of those sources was United Health Group. So let's pass the mic down to Andy. And Andy, you all have made substantial investments in affordable housing. And can you share with the audience a little bit about why you decided to do that and kind of what you've seen?
Sure. Thanks, first of all. Thanks so much for inviting me. It is truly an honor and a pleasure as somebody who spent 6 years now currently at a Fortune 5 global corporation to be among my people that I spent my previous 25 years with on the front lines. And so just a huge note of gratitude for all of you. I don't live here, but for all you do for the people in the community here. I'm grateful for all that you all do. At United Health Group, I mean, to your point, we have invested at this point well over $800 million in affordable housing over the last decade or so. And I think there's a few reasons for it, and I'll talk later about a couple of specific examples. But I think the very first and foremost reason why we invest in affordable housing is that housing is healthcare, right? Housing is essential to living a healthy life and being a healthy individual and a member of the community. Absent somewhere to live, it is literally impossible to be healthy and to thrive and to do all the things you can and want to do as an individual. And so I think for us, it is very mission aligned. We talk about helping to build a healthcare system that serves people better, and so we talk a lot about the healthcare system. We're acutely aware that the affordable housing system is a key component to that, as are other areas. But so I think really fundamentally, it aligns with our mission, and we've gotten that buy-in. I think the other thing I would say, just to be clear too, right, is that, and we are more than delighted and proud to be partnering with Kevin and team at Gulf Coast and look for ways to unequivocally provide kind of concessionary financing. That said, these are very solid investments, right? And so if anyone's from kind of the health system world and wondering if you should invest in housing, the short answer is yes. And I'll happily talk to you, and I'll talk to you again and again about why that is. Because if you think about it from where we sit and we look at the underwriting and find the right partners, we've worked with Enterprise in the past, we work with Kevin and team, and folks across the country that, if you look to make investments in affordable housing, from a financial perspective, you're not going to get some big return, but you'll get a modest return that, quite honestly, is commensurate with the risk, which is nearly zero. For those who think that investing in affordable housing is risky business, it is unequivocally not. And so just to say that from a financial perspective, it's not kind of the big winner that people are gonna yell from the mountaintops about, but it's really strong and fits in with, we're obviously a very large organization, but even in smaller organizations, it fits well within the investment portfolios of health systems across the country and insurers across the country and others. The final point I would make that from our perspective is important, right, is that as we're helping to build affordable housing, and in some cases co-located with FQHCs like the Pearl in Jackson, Mississippi that Kevin alluded to, right, that's also part of a community development and revitalization strategy, right? And so in order for people to be healthy, they have to live in healthy communities with access to care and those sorts of things. So not only do you have the benefit, right, for the individuals and families that are living living in the housing, but from our perspective, there's also a broader community development and community revitalization component to it that makes, again, kind of our North Star is the fact that housing is essential to health, and then there are these other, really strong rationales from both the business and community perspective.
Thanks, Andy. I really like the way you sort of characterize that the return is commensurate with the risk, and that investing in affordable housing isn't, I think, the risk that many people perceive it to be. So thank you for that. Allison, you offer a little bit of a different perspective, being somewhat outside of the housing and healthcare sectors, but you've done a lot of work in facilitating partnerships between healthcare and housing and community-based organizations. Can you tell us a little bit more about that? And I think you have your slides up?
Yep.
Perfect. Thank you.
Thanks, and thanks again to the organizers. This has been a fantastic day. Somebody earlier said that housing had the most acronyms, and I'm just gonna say no. Healthcare. I've spent my career in healthcare, and I just want to take a minute before I jump in and just break something down in case it's not completely obvious to everybody. Because when I started in my job 6 years ago, I spent an awful lot of time Googling while I was on conference calls. So the people have referred to managed care and managed care organizations. They operate in a capitated basis, which is basically if you're a Medicaid plan operating in a state, the state says, here's a fixed amount of money per member in a year. You spend more than that, that's on you. You spend less, you get to keep it. And that's just a little bit of like high-level paraphrasing, but that puts tremendous opportunity and pressure for behavior change. And that's the context that I wanted to share, I think, for everybody who's sort of sitting on the stage now, but also for the remarks I'll make, because I have really sort of built this work around that core notion of trying to engage partners for whom this work really matters meaningfully in a fiscal way as well. So Quantified Ventures, we are a social impact advisory firm based in DC, but we do work all across the country, and quite honestly, post-pandemic, have people all across the country. We are a B Corp. We are about a decade old, and our founding CEO thought he was going to start a tech firm and a fund, which is why we have this super wacky name. But in his wisdom, I think he looked around and he said, there's a lot of people with money, right? So again, going back to David's earlier comment, it's not an absence of money. What we see is that we have market failures or non-existent markets for the things we say we want and value in this world. And so it's been our job at Quantified Ventures to try to have a small role in mobilizing capital and coming up with creative financing solutions to address some of those stuck problems. And we work across the environment sector and the health and human services sector. So I can say like maybe one or two marginally smart things about the environment, and that's it. So I'll spend the rest of the time talking about health. So this slide, apologies, I know it's a little bit busy. I tried to have like the one slide to rule them all, which is everything we are and everything we do. The top like quarter is sort of like the why this is, what are the problems that we're trying to solve. The middle diagram is like what that actually looks like. And then the bottom are the benefits. But at a high level, we're like the deal flow people. So the reason my boss didn't start a fund is because he realized that there was a lot of money. There's a lot of money seeking investable solutions, but there's not a lot of work to actually create those opportunities, in part because people don't appreciate and understand the risk and the relationships that need to be explored as part of that. So we see in the health and human services space an incredible increasing demand for the services delivered by community-based organizations, including those that are housing related. And we heard a lot about that earlier today for the work that's being done for individuals experiencing homelessness. There is a ton of demand being applied through all sorts of means. And hasn't been the commensurate level of investment on the supply side to build capacity. And so that's one of the problems we really try to focus on. It is also harder, ironically, for community-based organizations to raise capital, and they work a lot harder to get the money that they do get than any other sector in the economy, and there's a slide on that later. There's a lack of viable earned revenue models for these organizations, and the investment capital tends to favor investment in sort of depreciable assets, so bricks and mortar. And I'm not saying that's a bad thing. Like, I love me some affordable housing, right? But I will say that housing people is part of it. There are a lot of services that need to come alongside in order to deal with a range of issues that people are experiencing that have put them in a precarious housing situation. So whether the root cause is, I mean, actually the root cause is poverty, but right, like then you like double click and it may be substance use disorder, or it may be a work issue, and all of those different reasons have different services that you would connect. So our job is to figure out how to bring together purposeful partnerships, largely with managed care organizations and community-based organizations, so they can figure out what shared value they have, how to design a program model that delivers the impact that they want to see and the change they want to see, and that attaches a monetary value to those outcomes and allows for those community-based organizations to earn revenue consistent with the value of that outcome. And I have a couple examples, so hopefully that'll make it more real. But just wanted to double click on a couple of the reasons before I go into the examples. One of them is, like, said no CBO leader ever, I have all the money I need coming in from various funding sources in order to cover the cost of my program. So when we look at programs that are operated across the country, depending on the type of service model, the gap in what they earn in revenue from fee-for-service Medicaid payments or other sources, you know, maybe it's a 20% gap, maybe it's a 50% gap, but nobody can build and scale a business model based on that, right? You can't deliver to meet the need in your community if that is your reality and you're always working hard to raise funding in your community in order to just deliver the status that you have. So I just wanted to make that point, because very often I'm in conversations with organizations like health plans talking about risk relationships, and they say, what is the risk that a community-based organization is going to take? And my answer is, they're already taking crazy amount of risk right there. They're delivering this service in an uncompensated way. And I also wanted to just point out this sort of notion I offered earlier, which is the sort of amount of work and time it takes to raise capital if you're a nonprofit is really different than if you're a governmental entity or private. And there's a lot of reasons for that. And I love David's, point this morning about equity for nonprofits, right? I think there's really a need. Right now, we're mostly working on the debt side, but I would be super excited to see an equity solution. So here's a couple of examples. We do a lot of work in the space of housing insecurity and homelessness. A lot of managed care organizations are getting pressure from their Medicaid and state partners to have more solutions for individuals experiencing homelessness. And while we're waiting for permanent supportive housing and affordable housing to be developed, there are things that you can do now, but the cost of delivering the service is inadequately financed. And so we helped put together a deal in Detroit where health plans basically agree to pay for the outcomes that we predict they will achieve. And that ends up being the collateral for the service organization in Detroit to access the capital they needed to finish their campaign and to build out the facility. And that's the type of model that we're working on across the country. Another example of that is a substance use disorder program for pregnant and parenting women. Again, it's a residential treatment facility before people are able to move into independent living situations. And the services are pretty intensive and therefore costly. And in order for them to operate that program without losing a ton of money, they needed to be paid in a different way. So we looked at their operating budget, we calculated the level of the gap, and then we identified the measures, the outcomes that they could achieve if they were financed adequately to deliver the service. And we got health plans in Kentucky to sign contracts that say, if you achieve these outcomes, this is the amount we will pay. And that ended up being enough for them to operate their program in the black, not the red, which means now they're in a position to scale and they're opening more facilities in the state of Kentucky. But no leader in a nonprofit, right, would say, sign me up, I'm gonna just lose money in more places. Obviously, they would be doing a great disservice to their community if they did that. So anyway, I'll leave with that example and look forward to the rest of the discussion.
Allison, that was great, and I'm actually glad you brought up the issue of the service part of it. We've talked a lot about the complexities of financing, building, preserving affordable housing, but you really touched on sort of the other aspect, which is housing is one thing, but often people who are living in affordable housing need additional supports and getting that. And as a representative of a nonprofit, I can tell you we never sit around and say, gosh, we just have money flowing out of our coffers here, no need to beg the next funder that comes into the room. So thanks so much for that. I'm going to ask Megan and Andy to comment a little bit on how you all have managed to keep housing sort of front and center in your organizations when, sort of in the pandemic and post-pandemic periods, healthcare has been stretched so thin and there are so many competing priorities. So Megan, why don't you go ahead and start?
Yeah, thanks. I think it's interesting. So I feel like I'm someone that works at a healthcare institution, but I spend most of my time doing housing. So part of it is that like vocabulary crosswalk that is essential. So I'm going to try to make sure I'm explaining this well, that I work at a hospital, but we are an integrated health system. And what does that mean? That means that we actually own a health plan too. And so we own both sides of the risk, right? If people show up and get care, we get paid. And then to an extent, if they don't show up and get care, there's both sides. So integrated, the most famous one is Kaiser, but there are other ones out there, UPMC or Intermountain or others that are able to in some ways think creatively about this. And so in some ways, what I'll answer the question of why has we kept it front and center is because we can't afford not to. Like we really do, like we've done deep analytics. Barbara talked about this morning in terms of trends for healthcare, is that we are doing value-based, to what Allison was talking about, this idea that it used to be fee-for-service. If you got sick, we got paid. And then if you came back again, we got paid. Now it really is about we're motivating you to get value, keep you healthy, and do better. So there's that, and then that has really led us to these deep data analytics. And so for us as a healthcare system, right, we've tried case management for homeless people. Guess what? It doesn't work that well. You can't find people, and you're still, like, it's just an amazing amount. You would say, like, well, that's duh. Like, of course you know that. But no, we can really, like, every health system has this data. So then what's our role as a health system trying to think about housing? And what are all the tools that we have available? We have potentially access to capital that we can bring in different ways. We can provide a lot of those services on site and think differently about them. We can engage, honestly, political capital and being able to get money for vouchers, money for new tax credits, the bond bills, things like that. So I feel like we're still at nascent stages, right? I will often joke, like, I used to have to give the Housing and Health Are Connected talk 20 years ago. I don't have to give that talk anymore. But to an extent, now it really is, well, how do housing and health work together? And how are we able to really catalyze and work with communities for what the options they want available? And sometimes that's home ownership, sometimes that's supportive housing, sometimes that's a community land trust. There are a lot of different options, but I think for us, it has to be a business model it can't be charity, and we know charity in perpetuity doesn't necessarily solve it. So we have to make it about business.
Great, thank you. So a couple of things. So one, I think that kind of bridge component is actually pretty critical. I spent most of my career in homelessness and affordable housing and have been now in healthcare for the last 6 years. So I think that's a good point, Megan. Something I'm going to say because she won't say it, but just to be very, very clear, it takes leadership, imagination, tenacity, perseverance of people like Megan to keep this high on the radar in organizations. So I want to, just commend you, Megan, but also, I think as we think about that, right, you have to be able to get that buy-in and leadership at the organizational level, and have those levers that you can pull and balance to try to make it work. But I think from my perspective, as we think about continuing to invest in affordable housing, because you're right, I get talking, well, why aren't we investing more here? Why aren't we doing and we're actually diversifying substantially, but I hear that question a lot, and I think, so for me, there's kind of a three-pronged answer. One is, and there's basically three value propositions that I stay up at night a lot about. One is the healthcare value proposition of investing in affordable housing, first and foremost. The second is, what's the business value proposition of investing in affordable housing? And then the third is, what is kind of some of the community, kind of reputational and community engagement value proposition of investing in affordable housing, right? So I think Megan's spot on, right, that the charity component doesn't work. And I'll say that as somebody who's raised a lot of money from philanthropy in my lifetime, but finding ways that you can actually finance things that aren't necessarily grants, where we are saying, where can we provide, some concessionary capital? In my opinion and experience, it actually leads to sustainability and replicability, the extent to which we're doing that. And so, we try at United Health Group to kind of demonstrate that there's these, 3 or 4 different very compelling reasons why we should continue to diversify and at the same time continue to invest in affordable housing.
That's great, Andy. So a couple of comments to that. First, the acronym thing. So actually my background is in health, not housing. And so when I came to Enterprise and people talked about the CDCs, and I was like, I know it's Centers for Disease Control, but there's only one. And it took me about 3 weeks before I realized, oh, they're talking about a different kind of CDC, a community development corporation. And so I do think, while Megan, to your point, that the conversation has certainly evolved, and to David's point earlier, I do think people believe the evidence is there now in a way that they didn't 20 years ago. There still is a bit of a gulf between the two sectors that really need to come together. I guess, Megan, I'd ask you, and then I'm going to ask Andy the same question, really about the partnership and an example that you could give our audience about a partnership that's really worked well between housing and healthcare that could serve as a sort of an inspiration to others in the audience who may be looking to pursue such a partnership.
Yeah, let me just piggyback on what Andy said about tenacity. So the story I want to tell is, so David mentioned this morning in the keynote that Boston Medical Center invested in this fund called the Healthy Neighborhood Equity Fund. And it was this amazing fund that was designed to provide equity to projects that were having trouble getting them otherwise. And what was really cool about the fund was that it would do a financial score on every deal, but it would also do a health impact score on every deal. And so it was great, and the team came to us and presented, and I will tease myself. I was like, I'm so happy you're talking about health equity, and they were like, Megan, it's a financial product. And so I was like, oh, okay, it's an equity fund. Okay, I get it. And so, but we brought it to our treasury team at Boston Medical Center, and they said no. And then we scheduled another meeting a couple months later, and they said no. And then we did it a third time, and they still said no. And so we were like, okay, what do we do next? And so what we did is we brought our treasurer out to the community, to one of the sites that was going to be invested in by this fund. And that's how we got to maybe. And then we got her to the point where then she was the biggest champion. She was the one shepherding us through the finance committee and getting this commitment and getting it across the thing. And so I really just want to, like, tenacity is really important to partnership building. So I'm just going to say that over. Don't take no for an answer. Keep trying. Get people out into the community so that they can see the stuff in action, because your finance team is your best friend. And so, but you have to be able to tap into their mission and get them out so that they can see it in action. I think one area that has been really exciting is we in pediatrics in 2016 started to think about, I talked about earlier, that housing prescription, right? I wanted to write the prescription, it wasn't stocked at the pharmacy, and so we did a pilot called Housing Prescriptions as Healthcare. And it was a cool partnership between a research policy network that I'm part of called Children's Health Watch, where we partnered with Boston Housing Authority that was willing to prioritize medically complex families. And we partnered with our medical legal partnership. We partnered with a local CDC called Nuestra Comunidad and a local community-based organization called Project Hope. And we actually, if you can believe it, tested this housing prescription in a pilot randomized controlled trial. So for those that aren't from the medical world, that's how we test drugs, right? We give you the medicine or we give you the sugar pill, and then we see whether or not which one works. And so we actually enrolled 78 families, and half of them got the flip of the coin to get the housing prescription, and half of them got what was usual care, which is here's a housing curated list, call as many as you can, good luck. And people may say oh my God, how did you get that through an ethics review board of a university? And they were like, you know what, everyone understands a lottery, and you're giving them really good odds of getting a housing unit that they wouldn't otherwise get. And so we actually evaluated it. This is actually in Health Affairs. We published it in the leading housing policy journal in 2022. And we showed that we were actually, I think it's actually April of 2020, we actually showed that this housing prescription, even after 6 months, we were seeing a 30% reduction in kids being in fair or poor health. We were seeing a full point difference, a huge reduction in parental anxiety, parental depression scores. And so what that led to was now we have built out a housing prescription program at our hospital using our hospital dollars, because we now see that this model can work. You can partner with your local housing authority. You can partner with local service organizations. We're building our own housing service organizations even within our four walls to be able to address those complex care families and individuals and be able to see that kind of triple bottom line: better care, better health, lower cost. And so that's been a great example.
Housing is health.
Great. So I'm going to cheat and give two examples, but I'll be brief.
Please do. Overachieving.
That's right. So the first is a couple of years ago we launched something called United Healthcare Catalyst, UHC Catalyst, and it's now in dozens of communities across the country. But in several of them, not all of them, we've actually created formal partnerships and collaborations between local public housing agencies, local federally qualified health centers, and other community-based organizations like Catholic Charities and Lutheran Social Services and food banks and you name it, where we have actually worked to, one, it's focused on listening to the community and engaging with the community and all those different stakeholders, and then shared decision-making in terms of the issues we're going to try to address with the PHA and the Federally Qualified Health Center and others at the table, and then co-creating solutions and interventions, right? And so it is a true collaboration where each entity is bringing its strengths and its capabilities to the table. I think Kevin alluded to it, right? That Kevin stays in the housing lane. He's not, you don't want him giving, a prescription, I don't think, as much as I love him, right? And so thinking about how we can each play that role in thinking about where you can more holistically bring together a host of different organizations that care deeply about that community, but in different ways and bring different capabilities and skills and analytics to it. And so that is one. And then the other on kind of the financial investment side of the equation is that we currently have a $200 million health and housing fund that we are implementing and investing in all across the country. And this is where, candidly, we use money as that tool, just to be very, very clear, right? And so that fund, that $200 million fund that we have, actually we have essentially requirements that we only invest in housing that has some connection between health and social services. And so we don't, through that fund, invest in kind of standalone housing. In some cases, it might be supportive housing, with a ton of services for families experiencing homelessness. Sometimes it might be, a care coordinator in senior housing. One of the things that I will have a bee in my bonnet about, I will admit, so I'm gonna share it here, is also thinking about where we can create partnerships between affordable housing developers and affordable housing developments and federally qualified health centers. If you look at almost any map, and I haven't looked at every city, but I've looked at enough to know that it's pretty true everywhere. If you were to look at where somebody's building affordable housing, the likelihood that there's some sort of health clinic within a handful of blocks there, or will be because of Kevin's work or somebody else's, is a lot. And if you think, how many people, raise your hand if you think that the head of the Federally Qualified Health Center and the head of the Housing Development Agency have ever met? They have not, right? And yet they have this kind of shared population of they're providing, housing to these residents, and other folks are providing, care and services. And so thinking about through that fund, we're trying to kind of create those partnerships and cultivate them. And then as part of that, we are also conceding a portion of our return on the investment to help provide seed financing for the services, right? We know it's no silver bullet, right? It's not 10-year money, but it is saying, look, here's what we value as a healthcare organization. We value the integration of housing with healthcare and social services, and we're going to demonstrate that value not only by this is how we do it, but also conceding on return to help make that a reality.
Great, thank you. Steve, next question for you. So I know these partnerships between housing groups and healthcare groups can take a while to develop and come to fruition. What do you think tipped the scales for you and your work with Intermountain?
I think, and this is interesting, I'm listening to the conference here, and there's so much emphasis in the housing world on affordable housing, low-income housing, because there's a significant need there, and there's a dramatic need across the country, and that need has been there for decades. The new need, and this is where we're focused, it's a lot less sexy to deal with 80 to 120% AMI kind of people. They're normal people. You think, well, they don't need help. But just a thought exercise, home equity is the #1 savings vehicle for middle-income America, and traditionally has been. And so now if you have 90% of that class of individuals that is no longer able to generate health or wealth that way, fast forward 40, 50, 60 years, and think about Venezuela or El Salvador, where you have a disenfranchised class of individuals that don't have a dog in the fight. They don't have a stake in the game. They no longer have anything to lose. And what are they going to be looking for? They're going to be looking for Uncle Sam, or in Utah we say Aunt Bee, Aunt Beehive. Florida, I'm not sure what, Uncle Orange, I'm not sure what it is here, but they'll be looking for the government to provide them retirement benefits beyond their effective employment years. That's what scares me, and that's why we're focused on the area that we're focused on, because, and that's what Intermountain, I think, saw as well, is that you've got this, for them, it's their employees. We have a number of employees from Intermountain Healthcare that are our initial clients. In fact, the first lady we put in was a physical therapist from Intermountain Healthcare, because they recognize that the health of their employment workforce for years to come is based on not only having the opportunity to have housing, but to have secure housing. One of the things that we see in rental housing a lot, and this is, I think, ubiquitous across the country, is that you have a lot of movement. And the movement from house to house to house to house in the rental communities, especially as rents are rising as they are right now due to the insurance issues and other things, you get a lack of stability in the education system for the kids. They perform less effectively in school. And so when you tie housing back to those social determinants of health, a homeowner's child is 4 times more likely to graduate from high school. They're 4 times less likely to become pregnant as a teenager and unwed. There are concrete things, and that's why I love what you're talking about. We can monetize those outcomes that produce real value. And so we're sort of a conduit, hopefully, to monetizing some of those things in our society that we're losing absent any sort of new model, because our current financial model is not working for most people.
Yeah, 2 great points about home ownership and the ability to accumulate wealth and then transfer that wealth to generations, across generations, clearly is an issue. And then, of course, just the value of reaching out to the 80 to the working, what we would call workforce housing. I think that's great. Kevin, I'd like to ask you that same question, because I know you've been working diligently on these partnerships. And so what do you think really brought them across the finish line?
Sure. I think it's funny. Andy and I were just talking a minute ago about how having one partner involved helps another. And our 6, 7, 8 years ago, we had this sort of concept of, if we improve health, maybe that'll be of interest to MCOs. And so just started knocking on doors and talking to people, and that tenacity, finding the right people, clearly important there. But I had going up to Jackson, Mississippi, there was one day where I had a meeting with the president of United Healthcare Community and State in Mississippi, and then the director of the Federally Qualified Health Center. We were trying to kind of court. And in the meeting with the guy from United Healthcare, he had said, if Jackson Hines is involved, we're really interested because we're so impressed with them. And in the meeting with Jackson Hines, they said, if United Healthcare is involved, we're really, and so, they were both technically involved that day. And so that kind of moved forward. But that's our role as a housing and community development organization with that expertise, is to also recognize where we have to have that overlapping connection. And so we were brought into Jackson by that group of churches who had grounding in community and had land, but didn't have that expertise. And then through some of those connections, we were able to start knocking on doors and got a lot of no's, or got a lot of that sounds wonderful, but it's not going to work. But slowly over time, we're able to make those connections. And then the more that we now have a pilot in Jackson, a pilot in New Orleans, we can move forward with more credibility for when we're knocking on the next door. And so it's been a very long journey in terms of getting folks together, and then even just understanding as we started to work with United Healthcare. If I'm talking to Andy, he gets it, but at a certain point, a decision gets made through a Treasury Department, and you have to be able to speak that language and understand what hurdles they may have. So we've learned a lot over the years on what is an easier investment for United Healthcare in terms of what type of asset it is, how that money comes into the transaction, and so I'm sure we could go through and knock on lots and lots of doors and try to get one really great investment from United Healthcare, but then because that approval had to come at such a high level, it's not going to be something that we can scale and repeat. Whereas if we can get an understanding of how they operate and their challenges, then we can say, okay, it doesn't. We did a new markets and low-income housing tax credit transaction in Jackson. The new market side of things did not work well for United Healthcare. We're not going to try to do a new markets transaction again. We're going to focus on LIHTC transactions where they can have a path to a first priority mortgage, because it's an easier way for them to have an admitted asset within the state in terms of how their accounting works. I didn't know any of that 6 months ago, but that's something that continuing to learn and question has been helpful there, and we have lots more to learn. So.
Yeah, education and really understanding what each sector, brings to the table, what their agendas are, what their goals are, really helps make those partnerships. Allison, from your experience, what would you say are the key ingredients that would make for a successful partnership between healthcare and housing? We've touched on a few, but curious about your perspective on this.
Yeah, I mean, I'll just go back to the comment that David made this morning about it's not an absence of data, it's not an absence of money. I usually say those same things and then I add it's an absence of will. And I think partially, and I don't assign malfeasance to that, I assign inertia because it's, humans and institutions are really good at doing what they've always done. And so from my perspective, and I don't at all mean this to be a shameless plug because I think each of us in our own way across our organizations is sort of like a roll up your sleeves kind of person, right? But somebody needs to be an interested intermediary, going back to that quarterback notion that was raised this morning, because it's nobody's job at any of these organizations, or it historically hasn't been anybody's job. Maybe it's starting to be somebody's job to think across the sectors in this way, to sort of take advantage of this real paradigm shift and the opportunity that comes with it to actually move dollars towards the things you care about that drive the impact you want to see. But everybody gets really busy doing their own thing, and so I think you need to be attentive to the fact that people have their day jobs. You need to figure out ways to sort of listen hard and have somebody dedicated to doing that listening and then doing that translation and active work across all the parties, because partnership really can only happen when somebody's really driving it. And it's great if everybody's equally driving it, but there are times when people are like, oh God, I need to take a break, right? Like, can somebody else do this for a while? So I think that, knowing within your organization what appetite you have for leaning in and driving versus having the wisdom to understand who else you need to engage to do that work, I think is also really important. And then the final thing I'll say is, I feel like we have to work backwards to work forwards. So always sort of aligning with those key goals and objectives that are shared, and always using that as a touchstone to understand how to go forward. But you have to know where you're going first and declare that really clearly to serve as that reference point, because it gets really hard sometimes and really slow, right? So
Great, really great points. Switching gears entirely now, let's talk a little bit about community engagement, because David touched on this in his keynote this morning around the need not just to do all of these things in a vacuum, but to really engage the community. And Andy, you had mentioned it in one of your examples about community engagement. This is a question, I think, for Steve and Kevin, really about learning more about how you've engaged community members in shaping the programs that you offer through your organizations. Steve?
It's a great point. I think what we've tried to do is, we started out with the school district, and we said to the school district, how many teachers do you have that need ownership in housing? How many do you have? And they said, we have no idea. So why don't you ask? And so they asked, and they found that there was a dramatic need, and that they started asking applicants and finding out who turned down a job because they couldn't afford housing in that area. And some have graduate degrees. These are not people that aren't accomplished and bankable, but they couldn't afford housing in the area around their thing. And now we found out that the universities, one of our universities in St. George, which is a fast-growing area, they lose 3 out of every 4 applicants, not applicants, but job accepted. So they accept a job, they come into town, and they look around and they say, I can't afford to live here. And they go to somewhere else where there is more affordable housing. And I'm guessing that's probably a very similar situation that happens here, because people want to create wealth in their lives. And so there's a huge role for the community to play in understanding that dynamic is going on, and then coming with solutions. And again, we're one solution to that problem, but that's where, from a county government standpoint, from a city government standpoint, they have tools in their toolkit and I like what you just said. It takes somebody committed to saying, oh, we need to look at this problem that is really difficult and figure out what solutions are there to that problem. And ownership and creating wealth is something that our middle class has depended on, and it's part of the American dream, right? I mean, that is the American dream. And so that loss of that potential has really had a significant impact in our communities at large, and I think it will continue to grow if we don't figure out how to solve some of the affordability issues that we're facing.
Kevin?
Sure. So I've mentioned a couple times that our role is really to have capacity in finance and real estate development, and Gulf Coast Housing Partnership is our name, and that's a really critical component. The Jackson example, where we first sort of started the path on this health and housing initiative, is a great example, because we can be for the group of churches, and there was a healthcare nonprofit that all sort of had this concept. They had pieces together, and they had a vision for what they wanted to be able to accomplish. There was a lot of missing pieces, but we could be that sort of force multiplier to move it forward, and then help to bring other pieces in. If we just have our own capacity in a vacuum without augmenting an existing idea or concept or partner, it's anything times zero is still zero, and so that's been an important piece in terms of those partnerships, is to sort of know what role we can play, and then let our community partners lead with us. Our other development in New Orleans is named H3C. And it's kind of one of those, nobody loves the name when you hear it for the first time, but it's the boulevard on which the development is an area we've been investing in for 15 to 20 years, and their mantra has always been community, culture, and commerce. Been very involved in a lot of those pieces, but in 2012, there was a study of that area that had a life expectancy that was 12 years lower than a zip code that was a couple blocks away. And so the H3C is health, community, culture, and commerce. And so that's really staying in our own lane, while kind of having tentacles out and asking lots of questions with community partners and then with other partners has been successful, not without challenges, but it's been successful so far. And kind of at every level, finding the right person who's willing to go outside of their opportunity or their job or whatever you want to call it, to be able to figure something out together has been a critical component of the success so far. And one of the positive sides of being able to do that with somebody who's in a community organization or at a Medicaid MCO is that while it takes a lot for somebody to go outside of their normal day-to-day, we do have something really cool that we're doing. And so if somebody has some opportunity within their community to do something more, or within their organization, if they're a chief medical officer in a state and has a lot of things that they have to deal with a large insurance company, they may be really excited about something like this. So that's kind of finding the right people, and being a force multiplier for communities that we serve has been our approach.
Great, thank you.
Stephanie, can I just add one thing?
Absolutely.
I have a real world example that I think will point to that question. So we just purchased an office building just on the edge of downtown Salt Lake, 14 stories, 217,000 square feet, largely vacant. We partnered with a LIHTC developer. They're getting a 9% LIHTC allocation for a portion of the building. They've got a $10 million grant from Salt Lake City to do that LIHTC housing, and so we're going to do a mixed income, mixed ownership development where we're taking the existing building, converting it into condos. We'll have some LIHTC housing in there. We'll have our program in there with people of higher income level, and then we'll build a second tower. We'll have an in-house subsidized daycare for the LIHTC folks. And that is an example of why community collaboration is necessary, because otherwise we end up with these sort of sinkholes of poverty where you get concentrations, and the kids of those families don't ever see anything else other than what they know. And so our sort of naive hope is that by mixing these income classes, you can create upward mobility for the kids in their future. So that's a sort of real-world example of that community collaboration.
Great, thanks. Kevin and Steve, you both touched on the impact that you all have been having in the work that you did earlier in your slide presentations, and I really appreciate that, because I'm going to now ask Megan, Andy, and Allison to talk a little bit about how you all measure success through the investments that you make, what you look for when you think about making an investment, or when you're counseling someone, bringing those partnerships together, about the impact that you hope to get, and just some general thoughts around impact, which, you know, from where I sit at Enterprise, is often challenging, because a lot of the impacts you see can be many years off and hard to measure. So, Megan, start with you.
Yeah, I'll start off. All right, how many people don't know what LIHTC is? All right, so LIHTC is the Low Income Housing Tax Credit, LIHTC. When I first joined Enterprise Partners Board in, I think it was like 2014, I spelled it out, right? Because I was like, LIHTC, and everyone was like, Megan, it's LIHTC. So anyway, there's a vocabulary lesson. It's hard, but it's good, because like we all need to speak each other's language. So yeah, it's interesting. I would say that I want to speak to outcomes both quantitatively and qualitatively, okay? And so part of it for us is quantitatively, we have really started to think a lot about ways in which our investments, we started off doing, in some ways, very more traditional investing strategies. We invested in an equity fund. We did low-cost concessionary capital to fill gaps in affordable housing developments. And we would measure that impact a lot of times in access to housing for our patients, our members, being able to look at the reduced healthcare costs and things like that. And we have that data, and it's not, in some ways, again, rocket science. If you take someone who is extremely housing unstable with a chronic disease or two, and they're cycling in and out of an emergency room or an inpatient stay, when you house them, their costs go down. We can talk a bit about kind of the nuances between someone who, say, has a substance use disorder and a behavioral health diagnosis, and they need this type of services that changes some of those calculations. But I think we measured it very much in that kind of return on investment. I think that over time, we actually have been thinking differently around, are our investments actually helping create wealth? And create wealth in communities that have been historically shut out of wealth creation by redlining and otherly structurally racist economic policies. And so we have pushed ourselves to lay out okay, how is our capital showing up in a way to create economic mobility and BIPOC wealth creation in the communities that we serve? And so I'll give you just a couple of examples most recently. And so we invested, there was a medium-sized business called City Fresh Foods that was started by two black men who were doing a lot of different types of food delivery, like Meals on Wheels, and were trying to get different contracts with the city. But they were in a warehouse that they didn't own, that the rent went up 150% over 3 years. And they were about to be displaced, and they had about 150 employees. And what they wanted was to buy their own warehouse space, design it for the right type of kind of contracts that they wanted to bid for, and they wanted to not leave the community, because otherwise, if they got displaced, then all of those jobs would get displaced too. And so we were able to show up with a long-term, honestly, a recoverable grant financing that we were saying, this is our commitment to helping you close this capital grant, that allowed them to purchase that warehouse. What that allowed them to do is then get the largest BIPOC-owned, operated business contract from the city of Boston to provide now meals to the Boston public school students that were culturally relevant. And this is an employee-owned business such that we said, don't give us the interest. We want you to use that interest to actually pay your workers a living wage according to the MIT living wage calculator and create new stock ownership opportunities for the projected 80 more employees that you were going to be hiring by having this new, better warehouse, right? And so like you start to like add up that ripple effect of what that looks like. For us, the other example that we've heard is, you know, community is asked all the time in some ways what they want, and then there's no tangible follow-up for what that is. And so there is an urban planning process for a neighborhood right next to our hospital in the Roxbury neighborhood, a neighborhood called Nubian Square. And everyone said they wanted a Trader Joe's. They wanted a place that they could go after work and get a fast meal and see their neighbors and get a gallon of milk if they needed it. And so this deal really evolved over time. We originally were gonna, we provided $1 million no interest loan because nobody would finance that in that neighborhood because there was no market for it. It didn't pencil. And so we were like, well, this is ridiculous. Like, you can't be a healthy neighborhood without a grocery store. So, like, let's figure out and lean into it. And what was incredible was we originally were investing in a group from DC that was going to start a new satellite grocery store. COVID hit. George Floyd's murder happened. And we said, wait a minute. And so a BIPOC entrepreneur team stepped forward, and we were like, wow. They said, we want to be the owners. And we want to own this commercial space, and we said yes. And we like leaned in to get the CDC to create a lease-to-own agreement, and we leaned in with more capital so they could redesign the store, and they envisioned it as a halal market with a cafe and a butcher shop. And this is right next to one of the largest mosques in New England. And so it was this like lean-in moment where like the community now is like, that tangibly is something we asked for and we now got. And so how do you measure that? Like literally like people walking into a grocery store that's selling like flesh-colored Band-Aids that are of different colors. And they say, I feel seen, right? And so like to me, like the numbers and cents and the ROI matters, but like this is about tangibly listening and showing up and being seen. And money, you gotta measure that too, because it's really meaningful.
Love that, Megan. Love that. I anticipate the red light going off momentarily.
Okay.
So,
That's
yes.
So real quickly, first, I actually need to go back to Allison's comment about inertia because we have a bit of a multi-year running joke in my organization where sometime many years ago somebody told me that betting against inertia is stupid. And I said, well, that stinks because that's the business I'm in. And so, I think that just going back to that tenacity part and thinking about like, here's what we got to be able to do. The two things I'll mention real quickly in terms of measuring impact. I guess one, I want to reiterate Megan's point that like the financials are what the financials are. That's not our focus. Like it needs to be whatever is concessionary but reasonable and that pencils out. That's honestly not where we focus most of our time and energy. People who approach me a lot get that way wrong because they always want to come and talk to me about the numbers, and I'm like, I don't care about the numbers. That's math. I want to talk about human beings and the impact that we can have. And so two examples I would give is, so one, we have a equitable health fund where we are building federally qualified health centers and other health clinics in very underserved communities. Our first one is MLK Center in South Central LA, and where we are looking, though, right, to measure the impact on healthcare access, right? I mean, access to healthcare is so key, right? So many people don't have it. So you could be insured, you could be on Medicaid or Medicare, or you could have employer-based care. But if you can't access care and navigate care, it doesn't matter, right? And so we think a lot about, and there's a number of other things I won't talk about that relate to kind of access to care and things that you can look at about how you're improving the health of that community and access to care in that community. And then the second thing I would mention is that I had mentioned earlier our $200 million health and housing fund. A key component of that fund from where we sit is that we are partnering with Stewards for Affordable Housing for the Future, SAFE, and working with their Housing as a Platform tools, and we're actually measuring resident health and wellness outcomes over a 4-year period. So not 12 months, but over 48 months. And we're measuring things, and then thinking about how we can address them too. But measuring things like physical well-being, mental well-being, access to primary care, food security, and then the one that we added about 1.5 years ago is around social isolation, which is a massive epidemic in our country at every income level, at every race level, at every gender level, at every level. And so thinking about, how we're working to kind of build and knit and weave communities back together. So I will stop there.
Okay, so I have failed my one job as a moderator, which was to allow time for audience questions, and I apologize for not doing that, but I got wrapped up in the conversation, which I hope you all did too. I would just ask our panelists if they would be available to the audience for a few minutes afterwards if there are any questions. I want to thank you all. This was really invigorating, very inspiring, really appreciate it. It was really an honor for me to moderate today, and I just want to thank you all.